One of the characteristic feature of lung adenocarcinoma is alterations in the receptor tyrosine kinase RAS pathway. KRAS mutations are one of the commonest alterations in lung adenocarcinoma. And the KRAS specific mutation, G12C, is the most common type among the KRAS mutant lung cancer. So the focus of the presentation at the meeting in the World Lung Congress was on an inhibitor of KRAS G12C called AMG 510. AMG 510 is a unique compound. It's a first-in-human novel compound that covalently and irreversibly binds to the G12C molecule, that is the mutant molecule of the KRAS gene protein. One of the important features here is that since it is very selective to the mutant protein, it will not affect the normal tissues, and therefore we expect very minimal normal tissue toxicities. And so this study is a phase 1 study. Basically, there are two components. The initial component of dose escalation cohorts, and the second one is a dose expansion cohort. And the study opened for accrual about a year ago. And we have accrued about 70 plus patients for the entire study as of July of 2019. And this presentation was focused on the 34 patients with non-small cell lung cancer. The patients ought to have received at least one line of chemotherapy. Although, as I pointed out at the meeting, 85% of patients got more than 2 regimens of systemic therapies, and some got up to 8. So it's a heavily pretreated population with a median number of prior treatment 3.5. And patients had to have KRAS G12C mutation tested in the tumor tissue, not in the peripheral blood. And these patients received AMG 510 at 4 different dose levels in the phase 1 dose escalation part, and then 960 milligram in the dose expansion cohort, because we determined based on pharmacokinetic measurements and the safety profile, 960 milligram is the safest, is the best dose. And we had 23 evaluable patients. That means those who had scanned 6 weeks without disease progression, or they have had follow-up at least up to 6 weeks. And I just want to remind the audience that the study opened just about a year ago, so many of our patients are still going through the early days of getting this therapy. But there are 2 important points I want to make. The first one is about safety. And while 3/4 of the patients had some form of AE, adverse events, only a third were attributed to the drug. And the most important take-home message here is that there were no grade 4 toxicities attributable to the drug. There were very minimal grade 3 toxicities, and no patient had severe adverse event related to the therapy. No patient had dose-limiting toxicities, and no patient discontinued therapy because of treatment-related adverse events. So that's number one. This is very reassuring because this is exactly what we predicted based on the medicinal chemistry and the preclinical models and what we know about this mutant protein. The second, which is even more reassuring, is the efficacy. And granted, this is a very short time for follow-up, but we saw a 50% response rate across the board, and another close to 45 to 50% had a stable disease. In all groups of patients, including the dose escalation cohort, we saw 96% disease control, whereas in the 960 milligram dose level, which is the dose level that's going to be tested in further future studies, the disease control rate was 100%. In other words, nobody had progressive disease on the first CAT scan, and 54% had partial responses. In terms of durability, it's too early to speak how durable these responses are, but again, fairly reassuring to know that we have at least 5 patients who are now going on 6 months, close to 6 months or longer. Again, others are in the early part of the treatment program. So over time, we will know median time to disease progression, durability, etc. But the early results are very, very reassuring, both in terms of safety and efficacy. And for the first time, we have a new compound for a group of patients that have been historically considered not targetable. And more importantly, hopefully this will open up the future research for various different approaches if the single agent therapy efficacy holds up in terms of combination, in terms of using it more earlier on in the frontline setting in metastatic non-small cell lung cancer, and hopefully at some day very soon in earlier stage non-small cell lung cancer, both in the adjuvant setting as well as in locally advanced non-small cell lung cancer.